Good afternoon. My name is Michael Schenk. I'm representing our working group 4 alone since Patrice unfortunately had to fly home and he had to catch his airplane. Yesterday we had a very interesting, fruitful discussion, and I'm going to present you the results of that. I will present the suggestions. We have 5 suggestions, as well a little bit the content of the presentations. So first, I think many things what I'm telling you now, it's very obvious, but maybe not for everybody. So the authorities should see chronic pain as a multi-dimensional health condition, and the approach should always biopsychosocial. What we know when we do advanced pain treatment, we have the bio approach and we have the psycho approach, but mostly we are lacking the social approach. So it's good we are talking about this. And also in my pain center in Berlin, where we do multimodal pain therapy, there's still a lack of the social approach. Chronic pain is associated with somatic morbidity, mortality, and many psychological disturbances, and has a very negative effect on social life and can cause loss of work. It costs a lot of money, and especially in Germany, what we found out, we have a lot of money, but patients get the wrong treatment. And this is also in many other European countries. So it's important that the patients get the right treatment. Health authorities, national governments, patients, very important, and other professional organizations should pool their forces to act in concert together, interdisciplinary, interprofessional, very important, to reach coverage of high-quality pain management empowered by networks. And here we have a very nice network. So I want to focus here now on 4 presentations. One was from my German colleague, Christine Kieselbach. She works in Freiburg at the University Hospital. And what she did for the region of Baden-Württemberg, which is in the southwest, to create a network with the graded care system in cooperation with the health authorities of Baden-Württemberg. She impressed us very much with her presentation and this project, but it still has to be filled up with life. Yeah? So it's starting. Then Wolfgang Jaksch from Austria, who is still here. I'm very happy. He works he was a former president of the Austrian Pain Society. He talked about the sometimes exhausting, but in the end successful work to advocate pain policy in Austria. In the morning we had breakfast together, and there we also talked about different problems what we have. My impression is we are getting better and better, step by step. Then Laura Fernandez from Barcelona gave us a very interesting example of e-health interventions. So we work on many different fields. E-health intervention means via the internet. I think it's very sophisticated, very interesting, and should also be used in other countries. But I think maybe we will not do this, but it would be good. And then Françoise Laroche from the Saint-Antoine University in Paris showed us her program of psychoeducation with behavioral therapy and exercise for chronic pain patients. So some nice examples about some projects. Our next was, this is number 3, cancer pain. Pain management in cancer should be an integral part of all phases and stages of comprehensive cancer management. It needs to become both a part of clinical and research protocols. This was very important also for my co-reporter, because in the cancer treatment there are many studies done, and it would be very smart to combine them with pain studies. Yeah, this would not be a big work, so I think it's a good idea. There were two speakers focusing on this topic. One was my friend Stefan Wirtz, who comes from Bad Honnef in Germany. Together with me, he is the speaker of the special interest group Cancer Pain for Germany, and he is also the chair of the special interest group Cancer Pain of the IASP. We wrote a paper, he was the first author, and that cancer pain can be chronic, especially in cancer survivors. And these patients are lost normally because they are treated, they are safe, they will not die, but they have ongoing pain. And the oncologists a little bit lose the interest normally. So we need to do something for them. The next speaker was Tit Albrecht from Slovenia. He works there at the National Institute of Public Health. He's an important man and a nice man because he's in charge of the cancer control project, the CanCon. The CanCon is a European project and to establish rules for screening, treatment, etc. for all Europe. And we made a big bombardment on him to put the cancer pain into his agenda. And now he is highly motivated to do it on the next CanCon meeting, and we hope to work with him together. Number 4. Health authorities and national governments must develop a structured approach to implement screening programs for early detection of patients at risk for chronification. Very smart, yeah? The yellow flags, this must do the GPs and the orthopedics. Especially in low back pain and postoperative pain, and then we need a care system with a stratified multimodal approach for in and out patients. What we added at the end, self-management programs and psychoeducation are effective and cost-effective tools to enable patients to manage their pain autonomously. There we had two nice presentations. One was from Pete Moore, maybe he's still here. He has a very well-established program for self-management of patients for chronic pain. You can find it in the internet. It's Pain Toolkit. It's one word, .org. And then Carina Raposo from Porto in Portugal demonstrated her concept of a pain school, which is also interesting. These are the small things which are very important. And for example, her pain school impressed me a lot because it seems to be very efficient. And we will do the same in Berlin now, I think. Number 5, and then we will be done very soon. Health authorities should follow up on the common position reached under the 2014 Italian presidency of the Council of the European Union by the ministers of the 28 EU member states on the need to create a European network ensuring training of professionals in the sector and exchange of information on the effectiveness and therapies for the weakest population groups. So in general, we can say pain patients are always the weakest population groups because they become pain patients because they are not so effectively cope with their pain, especially when they don't have the help from the authorities. And there we have two groups. We have the youths, the young people. It's neglected and misunderstood. And there we had a very nice presentation from Jordi Miró from Tarragona in Spain. And he spoke about the problem with young people as well as his good and smart concept. Then about the elderly patients, it should be recognized that as a percentage of the older adults increases, we have a higher incidence of pain. It's obvious, we know about this. So we have to focus on the old patients as well. And this was nicely demonstrated by Pat Schofield from Cambridge, from UK, who talked about the high prevalence of chronic disabling pain in the elderly and the need of a professional treatment. So we covered many different items in our working group 4. And last not least, it's not here. This was it's a statement from the Alma Ata Declaration of the WHO. People have the right and duty to participate individually and collectively in the planning and implementation of healthcare. And there I want to mention Robert Johnston from the European Patients Forum, EPF, who very nicely and very impressively explained why it's necessary to work together with the patients. And I think it's very good to get the feedback. So, yeah, I hope I didn't talk too long, because I think we are all tired, also with the word pain, but I think it was very interesting. Thank you very much.
Thank you very much.